जी में आता है तेरे दामन में सर झुका के हम रोते रहे तेरी भी आँखों में आंसुओं की नमी तो नहीं, तेरे बिना जिंदगी से कोई शिकवा तो नहीं, शिकवा नहीं, शिकवा नहीं, शिकवा नहीं, तेरे बिना जिंदगी भी लेकिन जिंदगी तो नहीं, जिंदगी नहीं, जिंदगी नहीं, जिंदगी नहीं.
Alrighty, so this video is for educational purposes only, and please never practice medical skills without the proper credentials. Our topic today is hypertension, which is a common household issue. It's a disorder that affects a large proportion of the world, and it's usually asymptomatic and often detected on routine examination or after something bad happens, like a heart attack or a stroke. When assessing a patient with hypertension in ED, the immediate priority would be like to distinguish a hypertensive emergency from a hypertensive urgency. We are going to cover that. Don't worry, don't panic. It's a new word for some people, but it's all right. We'll get there. And for the patient with a hypertensive urgency or with a new diagnosis of persisting hypertension, usually our priorities would be to begin investigations to make sure we are able to distinguish primary from secondary hypertension. And if this has not already been done, then we try to do these investigations and to formulate a plan, like a follow-up plan, okay? So in today's video, we are going to be touching base on hypertension, hypertensive urgency, and hypertensive emergency, and hopefully help you understand the difference, okay? All right, so speaking about hypertension, guys, normal blood pressure is 120 to 129 systolic and 80 to 84 diastolic. A high normal would be 130 to 139 systolic and 85 to 89 diastolic. Grade 1 mild hypertension, which is about 140 to 159 and 90 to 99 diastolic. And grade 2 moderate hypertension would be 160 to 179 systolic and 100 to 109 diastolic. And grade 3, which is severe hypertension, is usually more than or equal to 180 systolic and more than equal to 110 diastolic. Okay, let me grab some water. So it's important to know these values because you can gauge, is this high normal? Is this grade 2? Is this grade 3? And it will help you to, formulate a plan. So let's try to understand what are the different terms that I had used earlier. So severely elevated blood pressure is usually a blood pressure of 180 over 110 and usually without symptoms, okay? So that is called severely elevated blood pressure. There is no end organ damage or dysfunction. Acute end organ damage or dysfunction in hypertension is what we're looking for, and this means things like pulmonary edema, kidney failure, hypertensive encephalopathy, papilledema, or cerebrovascular hemorrhage. When you have a severely elevated blood pressure patient, there's no immediate threat to life as they don't have any end organ damage or dysfunction. When it comes to management, you do not want to drop the blood pressure immediately, okay? So you have a time frame to achieve initial BP reduction, and that's usually 1 to 2 days, and it's done by oral medications. The second word that I had used earlier was hypertensive urgency. So urgency, urgent. So in this situation, the blood pressure is 180 over 110, or it can be higher with symptoms, okay? The symptoms may include headache or dizziness. Acute end organ damage or dysfunction is not present. Moderate non-acute damage or dysfunction may be present. Your time frame to achieve an initial blood pressure reduction is ideally within hours. Initial management goal is to relieve symptoms and make the patient comfortable and try to reduce the blood pressure to a safe level below 180 systolic. And this is ideally done via oral medications. Hypertensive urgencies are not associated with end organ dysfunction. However, the risk of near-term decompensation is high, and blood pressure control over 24 to 72 hours will be the goal. The next word that I had used earlier was hypertensive emergency. So just as the name suggests, emergency. So blood pressure usually in this category is 220 over 140 or higher, and there are symptoms present. There is a significant end organ damage, or I would say acute end organ damage or dysfunction that is present. There is immediate threat to life. The initial management goals are to reduce the blood pressure quickly without causing a crazy drop or fall in the blood pressure. Avoid lowering the blood pressure more than 25% in the first 2 hours. And the blood pressure reduction is done via intravenous drugs in the hospital. So ideally in an ED, resus bay, or ICU or CCU with admission for ongoing management. A hypertensive emergency is a life-threatening event. In ED setting, ideally, these patients will have an insertion of an arterial line for invasive blood pressure monitoring, as this enables immediate recognition of any fluctuations that happen in the blood pressure. And the exact choice of drug in a hypertensive emergency with, it will primarily depend on the condition of the patient, and it would always be guided by your boss, your seniors. And even if it's guided by the seniors, you need to know the suitable agents. So the suitable agents are hydralazine or GTN or esmolol or labetalol or sodium nitroprusside. There are 3 major organ systems that are affected by chronic high blood pressure, okay? And these are number 1, the CNS, number 2, cardiovascular system, and number 3, the renal system. So if you can remember anything from this whole video, your takeaway would be these 3 things: CNS, cardiovascular system, and the renal system. These 3 are the most affected systems because of high blood pressure, okay? True hypertensive emergencies are quite uncommon, and a rapid reduction of an elevated blood pressure may cause more harm than good. And treatment must balance the risks of lowering blood pressure too rapidly with those of persistent hypertension. So let's see, what can be some of the common causes of hypertension in hospital? So when you start working in the hospital, you'll see a lot of pages coming through for review, so it'll be like patient in bed 3 south, BP 180 systolic, please review. So you go and you wonder, oh my God, what is it? So first thing, always pain. It could be somebody who is post-surgery or post-fall or post-fracture. So pain is one of the most common causes of hypertension in hospital. Then it could be a missed normal medication, like say somebody has hypertension and they are on normal, regular medications for hypertension, but because of sepsis or because of some issue, we withheld their antihypertensives. So in that case, they missed their normal medication, so blood pressure is going to shoot up, right? Another cause could be essential hypertension. So patients are usually asymptomatic in that case. It could be because of anxiety or stress. It could be something like a serious cause to consider, like malignant hypertension, which is quite rare. So think of this if, say, there's headaches, there's visual changes, there's focal neurology, there's raised intracerebral pressure. So like these are your red flags that you're looking at. If the person has hypertension and bradycardia, oh my God, that's not good. If somebody is post-stroke and you still want that cerebral perfusion to keep happening, do not lower the blood pressure unless it's greater than 180 over 110. And always, like in a stroke patient, we follow stroke guidelines. All right, so let's try to discuss a case. So I've got Lindsay Lohan, who is a 66-year-old female. She has a blood pressure of 180 over 95. Do you want me to do anything about this? So first, start by asking yourself, ask yourself some questions. What are the key questions to think of? What is the reason of admission? Could she be in pain? Is there a past history of hypertension? Is she on any blood pressure medications? Is she symptomatic or not? Does she have headache or blurred vision or nausea? Is she in pain? What is her usual blood pressure like? What has the blood pressure been like in hospital on the OBS chart? So have a look. Are the other OBS stable and normal? Like what's happening over there? Is she tachycardic? How are the oxygen sats? What about the temperature? Like, so have a look at all the OBS, okay? So we have a blood pressure of 180 over 95. Lindsay was admitted with gout this morning. Her past medical history involves hypertension, hyperlipidemia, and she's usually on atorvastatin and perindopril every day. The nurse says, look, she's in a bit of pain in the first metatarsophalangeal joint. No other pain or headache. Blood pressure on admission was 139 over 80, and then it became 130 over 60. And around midday, she's sitting at about 145 over 90. Heart rate is 90 and regular, sats 100% on room air. Her temperature is 37 degrees. So what is your management plan? Since it's probably related to pain, make sure she's written up for analgesia. For example, paracetamol, 1 gram orally, QID. Don't forget to check, does the patient have any allergies before giving any medication orders? You can give phone order for paracetamol through to the nurse. If the patient is already on paracetamol, then you want to think like, what else can you give them? So you can consider oxycodone, like 5 milligrams oral stat. If this case is not because of pain, does the patient have a background of hypertension or anxiety or, you know, in that case, then don't need to lower the blood pressure. You can say to the nurse, thanks for letting me know. Can you please recheck the blood pressure in an hour and let me know? If it's greater than 200 over 100, or if the patient has symptoms, please let me know immediately. So our goal again is to get the BP rechecked. Check again in 30 minutes or 1 hour. Ask to be rung back if the blood pressure is over 200 or you know, over 100 diastolic, or if the patient is starting to become symptomatic, say headaches, blurred vision, things like that. If the blood pressure is over 200 systolic or 100 diastolic, you probably want to see the patient and measure it yourself. And you want to do that manually, okay? So get the correct cuff size for a large patient. And if the blood pressure is still more than 220 systolic or more than 110 diastolic, then usually we need to treat and we need to find a cause as well. Don't be in a major hurry to lower the blood pressure because it can cause more problems like dizziness or nausea. All right. Let's do another case. So let me think. Mr. Bulla has a blood pressure of 220 over 110. What do you want to do? He was admitted due to cellulitis of the leg. He is asymptomatic from the hypertension. His leg is not painful. His past medical history involves ischemic heart disease, type 2 diabetes. He's on insulin, hypertension, AF, CCF. His usual medications are insulin, irbesartan, perindopril, warfarin, metoprolol, Lasix, flucloxacillin at the moment. Talking about his OBS, OBS are stable, pulse is 80, temperature is 36.7, respiratory rate is 12, sets are 98% on room air, okay? The nurse on duty repeats the blood pressure and it's 220 over 110. You go and take the blood pressure manually and it is 220 over 110. So what do you do? So the plan, well, lowering the blood pressure often causes more problems. Like I said, it can cause dizziness, especially if you're using like a GTN patch. So avoid the GTN patch for hypertension. If you need to lower, try oral medications first, like amlodipine, 2.5 to 5 milligrams stat. And if you want, you can go up in like 2.5 milligram of increments. Another dose can be given in like 1 to 2 hours. If the patient is already on a hypertensive, then, you can give an increased dose if not already on the maximum dose. Patient could have like extra dose beta blocker. This is, in this case, the patient is on metoprolol. So you could give another, say, 25 milligrams stat, if not bradycardic. Leave it to the unit to increase the regular antihypertensive medication if the patient is asymptomatic. Just chart like a stat order. You can also try other medications like ACE inhibitors or beta blockers, but amlodipine has little side effects and it's the most safe and effective. So to conclude, for the exam perspective, do not forget to look at the vital signs and keep in mind the difference. So severely elevated blood pressure, which is a blood pressure of 180 over 110 and without any end organ damage or dysfunction. And hypertensive urgency is a blood pressure that's 180 over 110 or higher with symptoms present. Hypertensive emergency would be a blood pressure which is 220 over 140 or higher with symptoms present. I hope this was useful information for you, and if it was, then please hit the like, share, and subscribe. And let me know if you have any further questions on hypertension. I'm more than happy to do another video if that's what it takes. Wishing you all the best. Have fun. Take care. Bye.